Hello, welcome everyone. A couple more people entering from the waiting room. All right, thank you all for joining us this morning. So I'm Kelsey. I'm the program manager with MapNet. So today we're very excited to hear from Dr. Cheryl Fu and Ken Farbstein about the promise and practice of family peer support in early psychosis services. So really a growing topic among, I think, a lot of our teams. So by way of brief introduction, Ken Farbstein, MPP, is joining as a family partner in Justice Resource Institute's PEACE team, which is a psychosis treatment program. He's also been very involved in advocacy around early psychosis. He helped win the CMS approval of two billing codes for coordinated specialty care for early psychosis. And is also the author of Getting Your Best Healthcare: Real World Stories for Patient Empowerment. So very, very happy to have Ken's perspective here as we
Mhm.
talk about really what is family peer support, and how can we do this well. Then we also have Dr. Cheryl Fu joining us. She's a clinical psychologist and a researcher who's focused on making evidence-based treatments for individuals with serious mental illness more accessible and used in community care settings. So she's the associate director of the Massachusetts General Hospital Center of Excellence for Psychosocial and Systemic Research. She's also the director of family services at the MGH First Episode and Early Psychosis Program and an instructor in psychology at Harvard Medical School. So thank you both so much for joining us today. I will not take up any more time. I'll pass it over to you.
Well, thank you so much, Kelsey, for inviting us. And it's really, really nice to see so many people joining us on this rainy Friday here in Massachusetts, and also so close to the holiday season. We're really excited to share and also learn more from you about family peer support. I think there might be some folks joining in from other states and programs as well. So we really want to leave a lot of room for discussion at the end. And, we're here because we think that family peers and family peer support is one of the most promising, but also untapped resource right now in early psychosis programs. Some quick acknowledgements before I begin. I'll be sharing a snippet of findings from a study that was supported by the LEAP Center, the Massachusetts EpiNet Hub that was funded by the National Institute of Mental Health and also with funding support from our DMH funded Center of Excellence for Psychosocial and Systemic Research. And today we wanted to represent the practices family peer support in Massachusetts. And we are really grateful for insights from leaders and providers at DMH, MapNet, Empath, as well as our Massachusetts CHR and First Episode programs. An outline of our talk today, I will introduce who family peer specialists are and explore why they can be valuable members of CHR, clinical high risk, as well as first episode psychosis, FEP, coordinated specialty care teams. And then Ken will bring his work as a family partner to life and really illustrate, the heart of our work. I'll zoom out again to talk about some models of how family peer support is integrated within our Massachusetts early psychosis care continuum. And then together, Ken and I will discuss considerations for integrating family peer support services well in these programs. We actually presented a similar version of this talk in August for the SAMHSA Early Psychosis Conference. Have updated it with some new emerging evidence as well as future directions. And like I said just now, very keen to learn from family peer models in your teams and states. So we'll leave time for discussion at the end. So, what is a family peer specialist? There are many names referring to this similar role. So, you've probably heard family partner, parent advocate, family peer navigator, and I'll refer to family peer in this presentation because I think it captures two important things. First, families. Families encompass, a broad range of caregivers and natural supports. So that includes parents, siblings, extended family members like grandparents, guardians, as well as trusted adults. And second, in the word peer, importantly, this captures the fact that a family peer is someone who has lived experience, expertise caring for someone with mental health challenges, and thus setting them apart from other care navigator or coordinator roles or case management roles who may not have, that lived experience expertise. Family peers can typically receive specialized training to support other families navigating a mental health diagnosis and navigating mental health services and systems. And because of their lived experience, they are equipped with the know-how of navigating these complex behavioral health systems. Family peers, there's a national certification through the National Federation of Families. And there are some states that do have state-specific certification as well. So, what do family peer specialists do? They have a multifaceted role. In the National Federation of Families, as well as other state certification and practice profiles. These NFF as well as the state practice profiles have described certain core competencies and core activities of family peers. And I particularly find Dr. Kimberly Hoagwood's categorization of the 5 types of support that family peers provide as the most simple and effective one to grasp. So I'll go through each one of them briefly, and then, briefly also map them to the evidence for family peers effectiveness. So, emotional and affirmational support is what families identify as one of the most valued aspect of family peer work. So, when a parent hears from another parent, you're not alone. What is happening to your child is not your fault. There are good treatments available, and this is what helps them. That can carry a weight that no clinician can match. Family peers can debunk myths about the mental health condition, offer hope for recovery, and also encourage resiliency in a person's mental health journey. Family peers can also provide education about mental illness and treatment options, almost becoming information brokers between what families are hearing from the internet, from their treatment teams, and sifting out what families really need to know from a lot of misinformation out there, and also share resources that they have discovered in their own journey. Some family peers also support families in developing skills. This can be through informal ways, by helping families prioritize and practice self-care, sharing their own strategies for coping with stress and caregiver burden. And some family peers can also formally teach communication skills as well as wellness and prevention and relapse prevention planning. And studies show that there's direct improvement in these skills through engagement with a family peer, as well as increasing confidence in the family's efficacy and self-efficacy in caring for their child. And finally, family peers also provide instrumental support through care navigation, connecting with services and community supports. And family peers have shown to improve service engagement and use of higher quality services as well. In addition, family peers can also advocate for and teach family members self-advocacy skills, helping families become active participants in their child's treatment. And studies have shown that family peer support have increased collaboration with the treatment team. So, for families of children with mental health challenges, family peer support is an effective process and highly and very well received by families. There's encouraging evidence as well that it translates not just to family outcomes, but to child outcomes through improving access to services as well as family education, or, indirectly through reducing family stress. Family peers now is increasingly seen as a way to address the shortage of specialized mental health and behavioral health providers. And this role is increasingly recognized with the bipartisan bill providing empathetic and effective recovery or peer support act, recently reintroduced to remove practice barriers and actually look to expand the peer and family peer workforce. And beyond that, beyond the evidence as well as the policies that are pushing more family peer visibility, I also believe that family peer support just offers a very unique and important value in improving clinical service quality. It aligns with the principles of patient-centered, recovery-oriented care, and also promotes family-centered, family-inclusive services that can better meet both youth as well as family needs. So a lot of the evidence that I just shared was coming from family peers for caregivers of children and youth with special needs as well as common mental illnesses. But I do think there's a strong fit and also strong need for family peers in early serious mental illness, like early psychosis as well. Firstly, as many of you know, caring for someone with psychosis brings unique challenges. This is often the first time the families are caring for someone with a chronic, multi-episodic, serious mental illness where recovery is not a smooth or linear journey, where there are multiple episodes of relapse or hospitalizations. And families are often learning for the first time how to communicate with their child who may maybe believe something very different from them or perceive things very differently from them. And some may face situations where their loved one is in fact paranoid about their family members. So having a family peer who understands that on an emotional level and have walked a mile further in the recovery journey can bring a lot of hope and wisdom. And secondly, we know that families play a very important role in psychosis recovery. Family stress can worsen psychotic symptoms as well as mood symptoms. And on the other hand, family support is a key cornerstone of our coordinated specialty care. And, we have decades of evidence showing that it enhances outcomes, in fact, reducing relapse rates by half compared to those who've never received family psychoeducation. However, compared to other coordinated specialty care components, family interventions, family support actually has one of the lowest uptake, with less than half of families receiving one session of evidence-based family intervention, like family psychoeducation or multifamily group, for example. And this is where I think family peers can actually be leveraged to address these challenges around family engagement and enhance the quality of family services in early psychosis programs. So, how can they do that? How can family peers promote family engagement? We have a little indication of that through our study done in Massachusetts with 9 of our first episode programs, where we looked at what posed as challenges to family engagement, as well as what characteristics, team characteristics, and engagement strategies were associated with higher family engagement rates. Overall, in our in the 9 first episode programs that we studied, the average rate of family engagement, which we measured as the number of families who had at least one attended session of family intervention visit during the whole program duration, so a very low benchmark. Actually, only 40% of families had that level of engagement in our first episode programs. And All the teams actually reported experiencing these following barriers to family engagement. Difficulty scheduling families during set 9 to 5 office hours, because a lot of families were working. Family stigma around receiving mental health services, families not appreciating the importance of their involvement and putting the responsibility on the treatment team to immediately fix, quote unquote, fix the psychosis, and also inadequate trained staff for evidence-based family services. Family peers are, in fact, uniquely positioned to address these barriers. They can overcome accessibility through community visits, visiting families in the neighborhood at their homes, also overcome stigma through their lived experience in education, and also bridge staffing gaps. On top of that, family peers are also well placed to provide supports that can promote family engagement. We found that higher family engagement teams reported prioritizing and providing case management and practical supports to families. As one provider said, families gravitate to the person meeting their immediate needs, and typically that was their family resource specialist. Um, and through our quantitative analysis, which we did find a signal that having family partners who could provide home visits or visits in the community was actually associated with marginally significantly higher family engagement rates. So this study kind of gives us a signal that family peers can have multiple valuable functions for supporting families in early psychosis care and have the ability to overcome many of the barriers to family involvement in treatment. When we did a literature review, there's some promising evidence for family peer support for people with serious mental illness. In the US, there is an RCT, a randomized clinical trial, showing that receiving NAMI's family to family education program increased families' ability to problem solve, their sense of empowerment, their knowledge about the illness, as well as reduced distress. There's also the Psychosis Reach Family Ambassador Peer Training Program led by Dr. Kate Hardy, Dr. Sarah Kapolovich, and team in Washington. And the Psychosis Reach program trains family peers to teach and coach other families in communication skills and cognitive behavioral therapy um, skills for psychosis, teach them in self-care, which families have found to really inspire hope, recovery, and also build their solidarity networks. Evidence of family peer support within early intervention teams like a CSC program is actually much slimmer. There are a few qualitative studies and kind of lessons learned implementation considerations for running family peer-led support groups and first episode programs coming out from Montreal, Canada, as well as the Origin program in Australia. Um, and more recently, this evidence base is actually growing in the US. So Dr. Oladuni Olawai from Washington State University is really pioneering a lot of this work in the US. And she very recently, hot off the press, published a pilot trial on a family motivational engagement strategy, or FAMES for short. This is a 12-week, low intensity, culturally responsive family intervention for families who are recently enrolled in coordinated specialty care. It consists of a modified cultural formulation interview that's done in the first month to really understand what are the important cultural as well as contextual social determinants of health factors that might impact a family's and as well as the client's help seeking and treatment engagement, what previous barriers they have experienced in mental health care, what their needs are currently, what types of resources they need. And then during the next 2 months, they have very short check-ins to support engagement and bridging with the families as well as the family clinicians on the coordinated specialty care team. They managed to reach 43 family members. 31 of them completed all 12 weeks of this short intervention, and many of them were highly satisfied. And some exploratory analyses showed that that those who had greater engagement in the FAMES intervention was associated with greater attendance of family psychoeducation sessions. So really tackling and addressing this engagement problem that many CSC programs are experiencing with family involvement. And in this pilot that they did around the COVID period, actually, it was two trained research coordinators that were embedded within the clinic delivering this intervention. One of them had a lived experience as a caregiver. So along with, this emerging evidence from this pilot trial, as well as what we've been discussing on the promise of family peers in early psychosis, Dr. Oluwai is actually currently conducting an R01 trial on the FAMES intervention of this tailored, culturally responsive family support to be delivered by family peers embedded and integrated within CSC programs. This really will be the first for our field, a trial for our field. Um, so I'm really excited to see what our team will find. I'll now pass it over to Ken Fartstein to really share his work as a family partner and bring this role to life. Ken, please.
Hi, thank you, Cheryl. So I came at this the hard way through experience. My son was 25 years old and had been descending into mental illness for a couple of years. Had graduated from some good colleges with bachelor's, 4-year bachelor's degree, and had been a good student in high school. I'd say good, confidentially good, but not great. Um, uh, a smart young man. But then had a psychotic break in October of 2015. And we then got him, so he was in the hospital and then in a partial hospitalization program, then came home and then we got him into a coordinated specialty care program for early psychosis, affiliated with Beth Israel Deaconess Medical Center in the Boston area, where he was seen by Michelle Friedman Jacobian. Hey, Michelle, thank you again. We attribute a lot of his recovery since then to that program. And he worked hard. We had to work hard. But at this point now, 10 years later, so he's, has his own apartment, his own job, and to celebrate 10 years without a relapse, 10 years of recovery, that, went in a trip to New York City and saw a Broadway show and a Michelin star restaurant. So things that he really couldn't have done, years before. So he's, we really think of him as a poster child, as a success story. And I think it was because of his experience that I got the job as a family partner. Much of the role, as Cheryl said, is really about building hope. That I was so, at Neil, when he had his psychotic break, I felt like, a truck had run over me. I think that's pretty common for parents of kids who develop early psychosis. So this sense of hope is really critical to them. And so sharing success stories and sharing the journey along the way is an important part of what I do. And also with clients now, I work at a kind of a coordinated specialty care program in through JRI. And one of my clients recently started, it's now December, so she's finishing her first semester at community college. This is a teenager, still 18, I think, who's had schizophrenia. She had thought she had active delusions and thought that people were watching her through the electrical sockets in her home. She's Cambodian American student. And when I attended just in the last year or so, attended an IEP meeting, individualized education plan meeting with some of her high school teachers. And her English teacher said that he hadn't realized that she had schizophrenia. So, I guess it was a mark of her recovery. So we can, we tell success stories like those, and take some pride in them. Another key part of the job is psychoeducation. And I really leaned heavily on the Navigate manual, which was developed by Kim User and Shirley Glynn, who's in this call. Thank you very much, Shirley. Really appreciate it. It's getting pretty dog-eared now, but still works. And we use the Navigate program, that Navigate model in our work with clients. So on our team, I should say, so there's an in-home therapist who does IRT and other kinds of therapy, and a peer specialist on our team. And we typically rely on the parents they have their own prescriber. So the psychoeducation is, I typically would go to the person's home, and then we might meet for privacy, might meet at a local coffee shop or in the library, or if it's nice, we'll go for a walk in the park or sit by the river or something, and talk for, about an hour once a week or so. And in the course of that, and going through the Navigate model, so early on, one of the things we do is a relapse prevention plan. And Cheryl mentioned how family partnering, family peer work can improve the clinical care that these people get. And I think a lot of from what I've heard from Kim User, that it's about preventing relapses, preventing rehospitalization, or a subsequent another use of the emergency department of the ER. So, and we do that through, there's actually a template of a relapse prevention plan in a book that I use a lot, The Complete Family Guide to Schizophrenia, which was written by Kim User and User and Gingrich, Susan Gingrich. Um, so there's a template there that we work through early on in our work with a family to say, well, what are the warning signs? What were the warning signs when the psychotic break happened last time? And what are we going to look for? What are we going to do if that happens, and so on? So it's a pretty simple plan, but pretty effective in a pinch. An example, and Cheryl, you also mentioned that easing the minds of family and giving them more information and empowering them. One example of that was with a Haitian American couple who I worked with. I worked with both the mother and the father, and they had thought, particularly the mom, had thought that she had passed schizophrenia to her now teenage daughter, and she felt quite guilt-ridden and ashamed, burdened by that. But there's a table early on in the Family Guide book that I mentioned that shows how insignificant genetic history is in schizophrenia, though it can be more important in other psychoses. But this was such a load off their mind. They were just so it was so much of an aha for them. So that's an example of the kind of psychoeducation that we do. So typically I'll read a couple of pages, we only get 2 or 3 pages through, read a paragraph of Family Guide to Schizophrenia, and stop every paragraph or so and then discuss our experiences about that. That's kind of the way we go through that. Cheryl, you also mentioned the case management component and how that can be helpful. So just to give a couple of examples about that, the Cambodian American girl who I mentioned had reported when I was there with them, and we were taking my mom had put her in the car with me to go to the local drugstore and get something, and the girl had said that she was feeling more crazy, and it turned out that it seemed like she was really on the road to a relapse, and so I was able to help them get into a partial hospitalization program instead of a full hospitalization. And so the girl had a very close relationship with her mom. And so they were able, in partial hospitalization program, the young patient sleeps at home, which I think was really big. And so we were able to avoid a hospitalization. Other times it's, maybe for a family that might live, way up on the North Shore of Boston suburb and yet have their psychiatrist visited, in Boston, that transportation can really be an issue, especially in the case here where the mother was really not comfortable driving in Boston city traffic. So we're able to get her a, a ride through Mass Health that was paid for by them. So there are other resources that we can connect the clients with as well, which are often can really help them. A lot of the clients I've worked with are English is their second language. They may be immigrant families, and so they may really not understand these American bureaucracies very well. Join the club, and so they can really benefit from some help in that. And then there's the advocacy and coordination is another chunk of my job. I mentioned the IEP meetings, and those are, I think that can be especially important where there is a language barrier, where the parents' first language is not English. Sometimes that they may not have had, and in some cases didn't have schooling in the U.S., in fact. And so, I don't know, for those of you parents who have, like me, who have been in our share of our own kids' individualized education plan meetings, IEP meetings, there's a lot of jargon that's thrown around. So it was really helpful for me. I mean, sometimes just to slow them down, and then also ask the mom in this case for her understanding of what was just said, for her to repeat it back, and then we could clarify that later. And also, in advance of those meetings, we do role playing to both to find out what are the parents' key questions that they want to be sure to have answered. A lot of these IEP meetings are very structured, and the teachers just race through them on their own agenda, and there's very little time for questions and discussion. And so that's not the best use of this meeting for the parent or for the kid who often is in those meetings. So it's good if you can really role play that a little bit and empower the parents to speak up and voice their concerns. There's also kind of a power gradient or authority gradient in meetings with a psychiatrist. A lot of times, if parents may not have a lot of education, they certainly don't have medical school education. And so it's also useful for us to role play those meetings ahead of time, the meetings, and also to identify what are their key questions in advance. Again, that often appointments with a psychiatrist are quite short, and so it's important that the parent needs to understand how they can get a word in edgewise. It's also helpful sometimes to role play the conversations, even just to set up an appointment. And how do you get an appointment? How do you get, you speak to the receptionist first, and then how do you go on to speak to to a clinician? So, in my mind, these are the four parts of the job. And the coordinating function, I guess, also to say that because coordinated specialty care is presumably coordinated, there are specialties. It does take some collaboration. And so one of the things I would do with one of the clients was to set up a monthly meeting among the care team and just to understand, okay, what have we learned in the last month that's significant? And then also for each of us, what is our goal for the next month? So to sum up, I mean, the four parts of this role, as I see it, the hope is really first and foremost, instilling hope, giving psychoeducation, helping get access to resources through kind of case management light, and also then how to collaborate and advocate for the family. Cheryl, if you wanted to talk, I think next about some of the different models of family peer support.
Yes, thank you so much, Ken. Really, for sharing your story again, and of course, sharing such inspiring work. As Ken was speaking, it made me think of, many family members who have I have connected with who are connected with both of us after this talk, and asking, how do I become a family peer, and something to add about how why this is also such a promising practice is because there are so many family members who either want to give back because they, like Ken, have had a really successful experience with early psychosis treatment programs, or, families who maybe not have not had such a successful experience um, with mental health services and want to improve or help other families, find a better path, and a less convoluted, less delayed path to getting the right kinds of supports. So really thankful to you for sharing this
Mm,
story and being such a strong advocate and partner for this role as well, Ken.
Thank you.
Um, I'll zoom out to share a little bit more about the models of family peer support in Massachusetts. For those who are joining this talk from outside of Massachusetts, Massachusetts has 10 first episode programs providing coordinated specialty care, most of them funded by our Department of Mental Health and following the Navigate model. And since 2021, with funding support from SAMHSA as well as our DMH, we built out four clinical high risk programs. I believe that number has recently increased. Three of them are co-located. I think perhaps four of them now are co-located with first episode programs as part of a stage-based care. And in late 2022, we launched Empath, the Massachusetts Psychosis Access and Triage Hub, which is our statewide referral and consultation service for psychosis. Thank you, Michelle, for correcting. We soon have 6 clinical high risk for psychosis programs in Massachusetts. And family peer support really starts right at Empath, right when youth and families seek help and want to get connected to early psychosis care. So, Empath provides family psychoeducation and family peer support during the time families wait to get enrolled in CSC services. And family peers can provide one-to-one support as frequent and as needed by the family, whether by telephone or in person, at home, or in community visits. The family peer also co-leads parent support groups and co-present with a clinical psychologist on family perspectives during provider trainings with the whole care continuum of behavioral health care. So with providing education on how to detect, screen for, as well as intervene with psychosis with general mental health providers, primary care physicians, pediatricians, school counselors. I do know that Empath had a wonderful family peer support specialist who has now gone down on her time. So I believe they are recruiting for a family peer specialist now. In our clinical high risk for psychosis programs, family peer support has not yet been systematically implemented. So teams currently are accessing family peer services through the Mass Health Children's Behavioral Health Initiative that provides wraparound services in the community for children and youth under 22 years with substantial behavioral health needs. So clinical high risk for psychosis providers have shared that family peers for CHR may not necessarily need to have a loved one who have experienced psychosis themselves, but as long as they have lived experience to help families understand what it means to have a child in treatment for a serious mental health condition, what it means for a child to possibly take medications for the longer term, navigating emergency room and hospitalization visits, as well as importantly, a family peer who can support another family in navigating the world of learning accommodations, IEP meetings, just like Ken does, and school placements for the first time for a child with substantial behavioral health needs. For our first episode, Psychosis Programs, we actually have several integration models with many of the teams doing a combination of this. So family peers can either engage in task sharing, where they are sharing tasks with a clinical provider. So, for example, co-leading individual one-to-one family psychoeducation, co-leading multifamily groups. This is or support groups, family support groups with another clinician, often a social worker or a clinical psychologist. Um, and some teams also have a task shifting model. So task shifting models, family peers, uh, such as Ken does in his role in Justice Resource Institute, family peers become trained to take on some activities that may be typically delivered by a family clinician. Teams who task shift typically are limited in their number of clinicians who can provide, high intensity weekly family interventions. So then family peers take on this role to provide basic psychoeducation on psychosis and guide wellness and relapse prevention planning, very much like what Ken had shared in his role. And almost all family peers assist in navigating these systems of care, helping families identify as well as advocate for resources, benefits that they can receive in the community. And another role, for family peers that was identified by some of the TMs that we spoke to in Massachusetts, but not yet implemented, is around how family peers can possibly extend or reinforce treatment in some ways. For example, around decision support. So guiding families to make treatment decisions. For example, talking more about disability benefits, for example, crafting out what questions they might want to ask to a supported employment and education specialist and help, guide making informed decisions with the family member and with, the treatment team. And teams also talked about the potential role of family peers to coach families in practicing motivational interviewing skills to help their loved ones engage in healthy behaviors or engage in treatment more. Right now, in our first episode, TMs, all of the family peers are integrated team members on the team. They are either part-time or are full-time. They join clinical rounds and they discuss and coordinate care for their clients with the other CSC providers. Right now, they are formally employed team members, providing typically non-billable services. So these roles are typically supported by grant funding. And they can provide different modes of contact, often meeting families at home or in the community. Here's what family peers and providers in our first episode teams say about having a family peer in the team. One family peer encouraged every team to have a family peer support specialist, sharing that one important benefit is their ability to reach families quicker, especially when families are in crisis. In the second quote, one team leader described co-leading family interventions with a family peer. And she said, I may have the clinical expertise, but families value hearing from someone who's been through it. And importantly, this hope piece can tell them that it gets better. They give real life experience as well as hope. And I think these quotes capture something essential that family peers not only complement, but also enhance our existing family services in early psychosis programs. One critical piece to integrating family peer support in teams is successfully is training and supervision. So in Massachusetts, we don't have a state certification for the family workforce, but we can leverage Mass Health's children's behavioral health initiatives, family partner training, which is done for any family member with who has a child with a substantial mental health service. Massachusetts also recently developed a family peer practice profile outlining core elements of family peer support that is a guide around what are the core competencies a family peer needs to have. What we currently provide in our for our first episode programs to build on your lived experience expertise is specialized training on psychosis as well as team-based care for our the family peers coming on board. So they're trained as Ken was in the Navigate coordinated specialty care model, as well as the family education program manual, and can join ongoing consultation with the lead Navigate trainers. And through MapNet, our technical assistance hub here, all our CSC providers, including family peers, can also access further psychosis specific training, like multifamily group, that is that is held by the peer team from Maine, and also join regular community calls such as this for continuing education. And through their lived experience, family peers also know about the breadth of services that clients and families can benefit from. And this wheel over here shows that breadth of what family peers need to be knowledgeable about. Mental health and health services, educational supports, legal systems, social benefits like SSI, SSDI, DMH services, and other resources to support psychosocial needs like food, housing and security, transportation services. And so having supervisors who are equipped to support family peers within the CST team is going to be really important. In Massachusetts, supervisors currently are psychologists or social workers in clinician or team leader roles within the teams. And supervision topics that come up consistently include how to use lived experience and disclosure appropriately and beneficially, um, how to set up appropriate contact frequency as well as boundaries to also protect them from being to protect family peers from being spread too thin and burning out. How to practice self-care as a family peer specialist, especially when they're sharing their own stories, or maybe, or may have a relative who's still in recovery, or sometimes, having a relapse or a crisis at the same time. How to manage confidentiality, such as how to speak with their own loved ones on how much they're willing to share their story with other people. And also how to scaffold and move from doing things for families to doing things together with families, and then supporting families to do so independently. And, this is how our landscape in Massachusetts looks like for family peers, but there definitely are challenges to integrating a role like this in our care system. So I'll pass it over to Ken to share some of the challenges and needs that he has experienced in his role as a family peer.
Sure. Thank you, Cheryl. And also just to add about the education, so it might be useful for me to just describe the kind of ongoing training that we get here. So in addition, I get weekly clinical supervision, and also I believe MapNet has the given a contract to Kim User to do education of family peers, of family partners. So Kim does that every other Monday morning, which has really been valuable to discuss individual cases. So thank you, Kelsey. Hope that that was true, that you do indeed do that. And I think it's an example, that uh, so so there's that, and then also some of the books that I tend to use a lot. I mentioned one of them. Another is "I Am Not Sick, I Don't Need Help" by Xavier Amador, which probably I'm sure it's familiar to a lot of you already. And for borderline personality disorder, it's a book called "Walking on Eggshells." Which is written for parents, or a couple of other books that I use. There's a group that Barbara Worsley at DMH gets family partners together again to talk to discuss our cases. And On Track New York has had a monthly call on Friday mornings among peers, not necessarily, and they let me kind of invite myself into that as a family peer. And so all those have been very helpful. And there are a bunch of webinars and podcasts that are mostly free, offered by MapNet, like this one, and by PepNet and other organizations as well. That's been very helpful. So because the job, you really do get better with experience, and there's so much to know that you really do need this kind of continuing education. Challenges. I think that the biggest one are the last bullet there about well, I'm getting ahead of myself a little bit, but part of the reason that there's difficulty in hiring and retaining people is because the jobs are not there, and they don't pay very much. And that's really, I mean, we have this fee for service system primarily, and family peers, family partners are not licensed or certified, as Cheryl discussed. So we're the low person on the totem pole, and so we're, trying to change that. There are now two billing codes that can be used, though they're very rarely used. We're trying to get them into wider use. Um, but right now, the funding is really an issue. So I'm quite lucky in my program, because we are considered a flex program, and the State Department of Mental Health gives us a contract to have our team, and so that's where my funding comes from. I think Massachusetts the leadership has been quite visionary in that, and I think we're one of the best, if not the best state in the country in that sense. Thank you very much, Margaret Guire. And but the funding that's a key limitation, and so it makes it hard to retain people, and to hire people. The role is new. It's not well specified. There is not there is the state. Cheryl, you described the work the state has been doing on for family peers, but to my knowledge, there's no certification for family partnering in psychosis. And psychosis is different. And a lot of clinicians who treat a lot of patients with depression, anxiety, and various neuroses do not feel comfortable talking about, helping people who have psychosis. And so the role is just not very well specified at this point. So I think that's why, we need to formalize it, and to do the training, to get the supervision, get the consultation, and create these learning communities. So that's a pretty ambitious wish list, I think, but that's uh,
And Ken, if I
that's,
can
that's the list.
add to that point, I'm thinking of the kind of supervision consultation type calls that we have. There is the one that Kim runs, which is more just family clinicians in general or people doing family work. And then you mentioned the peer calls. I think it points out there's a really interesting kind of in between here of both the family doing family work and peer work, and which part of that continuum do you fall more on, which is the more helpful resource to access? And to your point, is there a need for more specific community And does that more specific community kind of requires having more people doing this work and building out that network to begin with. I think that's a really important point.
Hmm. Yes, thank you for sure.
Absolutely. I think building out that network, building out that community of family peers are really important. I know, Ken, you shared with me that, there are there are kind of learning collaboratives or learning communities in a way for peers who themselves are in recovery or have lived experience as someone in recovery from a mental health condition, but family peers don't exactly fit in that group either. And so that I think that last point that you put about a learning community with other family peers is so vital, and I haven't seen that
Hmm.
here. Perhaps maybe P-PAL in Massachusetts is the closest one that I know of, but I'll be curious what's going on in other states as well, and if I'm missing out any in Massachusetts. Um, Thank you, Ken, for sharing your really important and I think, on point wish list. Um, First thing in terms of systems challenges that Ken has already pointed out is um, that lack of formalized and even specialized training and certification for family peers working with early psychosis, even family peers, full stop. I think we don't have that in Massachusetts currently, that certification and formalized recommended certification process compared to peer support specialists, which do have a certification. And we are really pretty early in the process of understanding what are the best practices, what qualification and skill sets are needed for this role, what specified job duties and roles they can play on the team, and also what the supervision guidelines can look like. So I think that's a lot of work to build out and to discuss with the input of family peers doing this work currently. Um, and I think integrating family peer support into CSC teams also raise questions about what would be cost-effective, sustainable models. Perhaps we can have that community and network of family peers for early psychosis within each of the states, psychosis hubs or technical assistance centers that can then be deployed to families who are interested in peer services. So a centralized kind of model rather than embedding family peers within each team. Um, that's one potential model to consider. And as many first episode programs across the US are also expanding to include folks who meet criteria for clinical high risk for psychosis or have a sister clinical high risk program that's part of stage-based care. Um, how would can we have family peers that work across CHR and first episode programs and serve both of this client population? For CHR, maybe compared to first episode psychosis, the family peer will probably need to be knowledgeable about developmentally appropriate approaches for teens and minors, know how to navigate school systems, and as well as, have the language around risk prevention. This then brings up questions also about who would be the right fit. Do you need someone who have experienced psychosis to work across CHR and first episode programs, or should you have two different sets of family peers? Or is it possible to just have a family peer with lived experience of a serious mental illness, for example, and knowing how to support another family and navigate the mental health system? um, more questions than we have answers. I think, as we showed the different models, we also need to think about how to clearly define family peer scope of practice, which roles are good or, meaningful to task share or task shift. And also, supervisors have much more demands on them to be able to advise on a role which maybe they have not played before. So, one supervisory structure to contemplate, which hasn't been implemented within our teams yet, but I do think that's been done in other states like California, is if a more senior family peer can provide supervision or mentorship, perhaps adjunctive to clinical supervision. So a senior family peer, again, have lived experience in both, as personal as well as their professional roles, and this also creates a career ladder for family peers. And finally, engagement with family peers have also been variable, depending also on what models of integration the team is using. But it also raises the question of if all families want or need family peer services, and maybe more types and modalities of family services, the better. And most significantly, I think as Ken had mentioned, we lack sustainable funding models. Current positions for family peers are grant funded, and are underpaid for what I believe is specialized work. So we need to think about sustaining this workforce, perhaps through bundled CSC rates. Thank you, Monica, for your comment and for your advocacy as well, which a lot of us have been advocating hard for. So some ongoing and upcoming efforts that are happening in this area include, let me see if I can advance this slide. Yes. Of course, Dr. Oladuni's Oluwai's trial of the FAMES intervention, delivered by family peers who are embedded within the CSE programs. So this trial is currently started. It's going to be tested with 8 CSE programs in the country, in New Mexico, Washington, Oregon, as well as with our Massachusetts General Hospital first episode and clinical high risk program. We are also interested in doing a landscape analysis, essentially taking a lay of the land of what types and models of family and family peer services are happening across the CSE programs in the US, and really just help us understand what the range of models are, how that might potentially relate to engagement rates, what gaps and needs there are around family services in our CSE services in the US. We also really excitingly started a working group with many of um, uh, um, leaders and clinician researchers who have been doing and advocating for better family services in early psychosis for a long time, and also, including family peers with lived experience. And one thing particularly that can as well as Dr. Michelle Fruitman-Yakuvian have been thinking and discussing a lot about is on how to, within Massachusetts as a start, have a consistent formalized recommendation for family peer training and understanding what more needs to be done there. And Monica Luke, who is on this call today and also shared with the working group, um, this recent launch of this very interesting and exciting program called Enduring Connections within Advocates, which is a large behavioral health organization in Massachusetts. And Enduring Connections is a program that is aimed at supporting families whose loved ones may not have benefited from or have not engaged with traditional mental health services, and looking to connect these families with peers and family peers who have navigated mental health challenges and systems and can support with communication skills and strategies. So all very new and budding efforts that we're excited about. I'll be curious to hear more about what other people are doing and thinking about as well. Um, so in some, we need more practice models, research, and discussion in order to widely implement family peer support in our early psychosis program. We know from the youth behavioral health field that it's an evidence-backed practice with a very strong fit and need for in our early psychosis recovery-oriented care. And I think we can leverage a lot of the learning health systems that we've already set up in, the early psychosis networks across the US to generate research, track outcomes of family peer services and family engagement, and continuously, improve our services in this way. I think, the next kind of frontier is really developing these best practices for hiring, training, supervision, service models for family peers, and also advocating for the resources and funding to sustain such a valuable service. So I think we're just beginning to center peer and family peer work in our recovery-oriented early psychosis CSC care. So I'm excited to see how it grows in, the next 5 years, the next decade. Thank you everyone for your attention. We've posed a few questions here. Would love to learn from you what have been successful family peer support models in your programs, and how maybe you've addressed or are thinking to address some of these implementation challenges. Thank you. Ken, feel free to add anything I've missed too.
Right. Okay. Hmm. It's not something not Cheryl, not something that you missed, something that I left
Mm,
out. That our program is really a strength-based program, and so if we find out, well, when a girl really likes to dance, well, that can then be, so how do we, we know that exercise is hugely important for people's health in psychosis and everything else. So okay, so dance is that's what we're gonna get her, make sure that she does a lot of that. It just is one example, but we really look for what the young people's strengths are and work from that.
Thank you both for all of this information. I feel like I'm always impressed by, it's still a very emerging process and we're kind of learning as we go, but there is a
mm,
lot of work happening and about to kind of build community around this. One question that I got, and I know there's been some conversation in the chat already, is really around that how we're paying for this. What are the models that we can either advocate for or be putting more attention in? I know we talked a little bit about, team-based payment, but what are your thoughts on that as far as kind of next steps or hopes for future directions?
Oh, I can speak to that, Cheryl. Maybe you have comments to add also, but um, so well, their mass health, their Medicaid, state Medicaid agencies pay for a lot of behavioral health, of course, psychosis treatment, and commercial insurers pay for it as well. Um, Typically, we hear that the commercial insurers take their lead from the Medicaid state agencies. Um, in some of the nationally, some of the state Medicaid agencies have been more aggressive than others in it. Um, that what we understand is that a Medicaid state plan amendment is needed. Um, so CMS already approved these billing codes. They're in use a little bit, not very much, but for the most part, is that there's a formal Medicaid state plan and that it needs a formal amendment. And it turns out that several states have gotten that already. Hawaii, even during the Trump second Trump administration. And so we're hoping to learn at an advocacy group that I'm involved with at the state level with Kelsey, Michelle, Monica, that and others that we're hoping to have the state Medicaid agency to, submit the state plan amendment. And we hear from an expert, a very well-respected consultant who we've worked with, that that's a purely administrative process, that politics doesn't come into that. So and that's Hawaii, as I said, got that very recently. So we're hoping that would then open the way for Medicaid funding here in state through Mass Health. Um, and on the commercial insurance side, um, so the insurance company that is farthest along, that's leading the way, is Optum. Um, and so they are now working with some provider groups here in Massachusetts and elsewhere in the country to get some experience and with that and see how it works, what should the rate be, and so on. Um, so I'm working with a VP at Optum. We're submitting an article for manuscript for a financial audience, mostly to say, don't be scared. It could save money by reducing hospitalization, reducing ER use, but in an event, it's not going to cost a lot of money. It's not going to break their budgets. So we're hoping to encourage commercial insurers to pay for more coordinated specialty care. I mean, there is a national parity law. There is a state parity law. They both say that behavioral health, that the threshold, should be no higher. I mean, if somebody has cancer, they're going to get cancer care. And and they're going to and that so we hope that for solidly evidence-based care like coordinated specialty care for early psychosis, that the evidence is clear. The American Psychological Association has said that thou shalt do this, and the American Psychiatric Association has said this is the standard of care. So it's not, the value of the clinical care is not in question. It should be covered. We're trying to get that done and Kelsey and Monica, Michelle, you all can speak to this as well as I can too, if you want to go in that direction.
Yeah, Monica.
So
I would love to add just one thing to that. That was a great summary overall, Ken, and no wonder I can't see anything. I don't have my glasses on. Um,
hmm.
is that the inclusion of a family peer supporter in a coordinated specialty care team would be up to the team to decide. It's a multidisciplinary team. So if you go after the multiple ways that you can get a team-based rate, which I think Ken did a great job of taking you through what's going on with commercial insurance, what's going on with Medicaid, but getting out of the problem of this type of care is not covered and has to be grant-based or otherwise scraped together, the team-based rate gets you out of that problem. And that's true for peer supports. That's true for rehabilitative supports for school and um, uh, job employment. Um, so understanding that doing the work to get your program reimbursed as a team-based rate gets you out of all these other problems. So yes, it's work to get there, but once you're there, you don't have to deal with this stuff anymore.
Michelle, you're gonna add something?
I was gonna I was gonna ask some of our audience a question instead, not
Mhm.
necessarily related to funding, but I see we have some friends from different states. I've gotten to work with Kristen and I've talked with Scott. I'm really curious if, I know I'm putting you on the spot, but if anyone from other states would be willing to kind of share with us, how you go about this. Ken and Cheryl, I think you did such an amazing job of summarizing the field and where we're at. And if we have an opportunity to learn more from our participants today, I would be very grateful.
Hi, Michelle. I'd be willing to speak. I was actually starting to write something, but yes, I've appreciated being on this call. I have lived experience with both a son and a daughter in recovery with psychosis and other comorbids. So I have been working with UNC Chapel Hill and started out with an online platform called Altitudes, where we were supporting. I started out as a caregiver, but then transitioned to be a family support, helping navigate online with families over text messaging and through the platform. And then it has evolved to now I'm being more in the clinic and still primarily meeting families in the community, taking walks in the park, a lot of texting, a lot of emails that fit with, like what you were saying, a family schedule that maybe they can send a text, in the middle of everything else and on the weekends and when convenient for them. So that's been great. And I am pursuing certification through UNCG through Voices Amplified. I did some initial training with Origin in Australia. I saw you mentioned them. And I also did the Psychosis Reach training program, which was incredible, both personally and that I can share with families.
Oh,
So thank you for having me here.
wonderful to get connected with you, Kristen. That's amazing, range of training and in just your own personal experience that you bring to the table.
Hey
Yeah,
everybody.
surely. Oh, sorry.
No,
Yeah,
go ahead.
you can go ahead, Scott. I don't want to interrupt you.
No problem. Thanks. Good to see you, Michelle. Thank you for your work, Ken. I think you and I exchanged an email about releasing the paper um, some time ago, or in your advocacy work. I've met some of you, but for those who you don't know, my name's Scott Palazzolo. I work with Kat Etch and Kathy Adams in Michigan, and we're involved with the early psychosis programming and support and training. And most of my work actually focuses around supported employment and education and the family clinicians. But I'm now kind of dabbling working with the family peers as well, which I've learned a ton and is very humbling. And so I was very intrigued when I saw this call. And so a lot of our work is it's an amalgamation, I suppose, of work that's been done out of Minnesota with the Navigate work, and then we pulled from some things from Origin
Mm,
because their work is top notch. And then we've had a couple of the peers kind of co-create a manual of sorts, and that includes work from On Track. Um, so those are some of the tasks of supporting family members from their manual. And then we are using P-Reach as well. I'm actually in the process of getting trained in that, which is a bear and a lot to learn and intense, but really lovely for families. Um,
Scott, what
so
is P-Reach?
Psychosis Reach, Sarah, Kate Hardy,
Psychosis Reach. Yeah.
yeah, sorry, Psychosis Reach. Uh, So, sorry, I have a young daughter who's not sleeping at all. So I hope some of that made a little bit of sense. And this has been a really helpful call. I did have a question about the work groups. Like, are those only for Massachusetts clinicians, or are those like with
no. We would
No?
love for you to join. I mean,
Okay, that would be
we
really
started
cool.
small with Massachusetts. So Dr. Margaret Geyer, Dr. Michelle Friedman Kuvian, me, Ken, Kim User, Monica Luke, Dr. Julie McCarthy is in there, and then also Dr. Duni Oluwai from Washington State.
Oh,
Um,
wow.
so there's more of a Massachusetts presence currently, but we just started it. So really welcome more of you on board. And really, the purpose is really to advance family inclusive care in all directions, and would love to get like a statewide learning community,
Yeah,
a nationwide learning community together.
that'd be great to be part of that. Always looking to kind of deepen skills and training and connect with other people that are doing this work.
Awesome. Please, I'll drop my email in the chat.
Okay,
If you
sweet.
can just like quickly email me, I'll send you an invite.
Stellar. Great.
This is open to anyone else too on the call. Dr. Glenn, it's so nice to
Hey,
see
hi.
you.
Hi, Cheryl. A couple of one thought and a couple of questions. First of all, I just really want to commend your work. I think this is terrific. I think involving families with lived experience to really bridge to other families, given our engagement problems, is terrific. Um, Two questions. Years and years ago, I mean, really like 20 years ago, we tried a program sort of like a family peer program in Southern California to try to promote Asian families with somebody who had newly diagnosed with psychosis to come in. And interestingly, what we found is the many of the Asian families with the ill family member did not want a family peer because they were so concerned about stigma. They really didn't want anyone else, and they wanted someone else, not from their community, to be sort of helping them navigate. So I'd love to hear your comments about that. I know Tony's doing work on this stuff. I mean, it's tricky. And then the other thing is, what do you think makes a good family care coordinator? Because you can write, of course, your duties on a job description. But when you're really trying to interview for somebody, what are you looking at? And what are you looking for? So those are my questions, and I'd love to hear any expertise anybody has.
Ken, do you want to take them first, or I'll be happy to take the first one.
Go ahead. Yeah.
Um, yeah, no, I think it's, and I think that's why I briefly said that maybe we need more, that family peer services cannot be the only modality of service that we offer as well. Like, I think that the more types of services that we can provide, the more it can be tailored, or people can really choose what they prefer. What I definitely have had clients as well from Asian backgrounds who and other cultural backgrounds who really see the doctor as the holder of expertise and who has the most credibility, and so would prefer not seeing, would prefer actually not having contact with other families. We see that a lot in the multifamily groups that we run as well. What typically comes up as initial concerns, that and this is across all racial and ethnic and cultural groups. There are some families who are really pulling for another family member's perspective, like a family peer's perspective, that, okay, someone who has walked this road before, and this is going to be really inspiring and helpful for me. And then we've also heard families who's like, no, I am not as sick as other family members, and so I don't want to join such a group, or I am, or these family members won't understand me, and they're just not ready to meet with other peers, other family members who have experienced the same things before. Typically, once they do join at a much later stage, they do like it. So I think there's a matter of, different entry points, I guess, for engagement down the road. But I think two things: having a variety of services, and also, and that's why I really like the FAMES intervention that Dr. Oluwa is doing, because it starts off with really meeting them where they're at, culturally understanding their culture, and their addressing some of the stigma concerns that they might have with mental health services based on their past experiences and based on their culture as well, um, before throwing them into the deep end of like, join our services. Yeah.
And I'll just speak to the second
Mhm.
question, Dr. Glenn, about qualifications. I think ability just to describe, to describe their own story and accentuating the positive, because there's still a lot of negative. It's a very bumpy road, as you know. Um, so that's the basics, I think. And to listen to them, see what their concerns are, is also key. And then this is a little irreverent, but the programs, I mean, it's hard to find these people, right? And so I think a lot of the programs wind up not being very choosy. I mean, I think, um, I'll just say that and just let it stop there, I think. But yeah.
Thank you, both of you.
Michelle, you have your hand up again?
I was just reminded, so Dr. Oluwai in our working group meeting had mentioned something about one of her studies, and I thought this was fascinating that she had, I don't know exactly which intervention she was talking about, but there were pretty low rates of families engaging in coordinated specialty care.
Yeah.
However, they were really happy to have someone to talk to, just someone to talk to, right? To connect. They didn't necessarily want to come to the treatment team meetings and do all the things, but having a person on their terms kind of reach out and connect was really meaningful. And there was a lot. I thought that was fascinating and something we could really learn from as we think about this idea of family engagement. And yes, and I have a part two, which is I'm just curious if we developed more opportunities for there to be a path for family members to learn about becoming family peers, would that lead to more people deciding to be family peers and help us increase that workforce and opportunities? Just curious.
I love that thought. That thought, Michelle. Um, because after one of this, when we presented this talk at SAMHSA, I had a conversation with the peer team at Maine, so Maine Health, with Sarah Lynch. And what they have is and I think, ESA at Oregon has that too, like a family as well as a youth advisory council for graduates of the program. And so they naturally have this, ongoing kind of alumni program. And so a lot of their peers and family peers are coming as graduates from their programs, and then there's this natural pathway and pipeline for them. So I really like the idea of, a somewhat of an alumni program, a advisory council, if you may, and then really um, funneling in providing the trainings for people to become peers or family peers through that.
Oh, ditto. And Michelle, and to your first point about, someone to talk to, it's important that I think family peer be available in after work. If most of these parents have to work and most of them work in a 9 to 5 kind of job, that you have to be able to see them when they can. So that's another requirement for the job.
There's so many great comments in the chat. Not to put you on the spot, Kelsey, but I wondered if you might want to share a little bit. I don't know which team you're from.
Sure, yeah. I'm from Turning Point, which is an unfortunate name currently, but Turning Point in Fairfax
Mhm.
County in Virginia. And yeah, we're very lucky to have a peer, family peer support partner in our program. And she actually had the journey that you guys were just talking about. She was very involved in our CSC model, came to groups, and then slowly, as she attended groups, kind of shifted to more of that like wizened voice in group, and ultimately pursued this as her new path. So we're really lucky to have her. But We definitely have seen an increase in engagement with families with having her there. She's almost like a safe person. If we introduce
Mhm.
her early, they're kind of like, oh, this person gets me, and she's able to be kind of a buddy and help them like go to groups for the first time or advocate
That's
for
so
themselves
nice.
within the team, which is really awesome. And then also, I think my other comment was just that our larger agency, she's actually the only peer, family peer in our entire agency. So I think there is a lot of confusion about her role and what she does. And we've had to be really protective and defensive against some peer role drift, like trying to put some extra case management tasks on her agenda or trying to kind of involve her in some more purely clinical work. So we've had to do a lot of psychoeducation and a lot of defense about defending that role as purely a peer role and like explaining what that is and how it works.
Thank you so much for sharing, Kelsey.
And thank you, everybody, for the awesome questions and chat. I encourage folks to read it. But also, please do reach out. As we've talked about, we're actively kind of building out a work group for this. So, would love to keep the conversation going.
Yes, let me quickly drop my email in the chat. It's sifu1@mgh.harvard.edu. Our next working group meeting, I believe, is January 20th, 12 to 1 p.m. And then from there, we'll try to figure out a good standing time for everyone. But please feel free to write to me. I'll make sure to include you.
Great. Well, that I know we're right after 1 o'clock. So, thank you, everyone, for joining us today, and happy holidays.
Thank you.
Be well.
Happy holidays.